Okay, folks, I'm Mo Chowdhury. I'm a consultant neurologist here. Going to talk about management of the unconscious patient. I think the format of this talk was meant to be, one of you guys was meant to do like a case presentation of a sort of representative case, but I think the person who was meant to be doing that was unavailable. So unfortunately, this is going to be a bit of a didactic lecture as a result, but I'll try and keep it as interactive as possible. So if anybody wants to chip in with questions, I think there's a microphone somewhere around there that you need to use if you wanted to ask questions, but I'll get going. So first of all, just a few ideas in terms of definitions. What do we mean by loss of consciousness? Well, basically, loss of consciousness is sort of loss of awareness or perception of the environment or of any sensory stimuli. And an easy way of stating or measuring a loss of awareness is by what we call the GCS score, which I'm sure you're all familiar with, the Glasgow Coma Scale. Essentially, a Glasgow Coma Scale of 15 is a patient who's fully conscious, fully aware. Coma score of between 14 and 8 is associated with some impairment of consciousness or delirium. And sort of between 3 and 8 patients are very hard to rouse or unrousable, essentially. And as you're probably aware, the GCS is kind of split into 3 parameters. One is eye-opening, and there are various scores given. So a patient who's spontaneously opening their eyes is given a score of 4. A patient who only opens their eyes in response to being spoken to or called is given a score of 3. A patient who is only able to open their eyes in response to painful stimulus is given a score of 2. And the lowest possible score is 1, where they're not opening their eyes even to painful stimuli. And then in terms of verbal response, which is another parameter that's measured, a maximum score is 5 if their speech is orientated, spontaneous. A score of 4 is given if their speech is felt to be confused. A score of 3 is given if their speech is thought to be inappropriate, or sort of not making much sense. Score of 2 is if their speech is completely incomprehensible, and a score of 1, which is the lowest score, is if they're unable to speak at all. And then finally, there's the parameter of motor response. Score of 6 is if they obey commands appropriately. Score of 5 is if they do not obey any verbal commands, they localize to pain. Score of 4 is if they withdraw to pain. Score of 3 is what we call decorticate posturing. So in response to painful stimulus, they produce a flexion posture. Score of 2 is decerebrate posturing, where they produce an extension posture. And score of 1 is if there is no response whatsoever. So in terms of the physiology of loss of awareness, as far as the brain is concerned, there's only 2 things you really need to know about. Impairment of consciousness is either to diffuse bilateral cortical pathology or due to a brainstem pathology. So it's either one of those 2, maybe a combination of both. Okay. So if the brainstem is functioning normally, then if patients have impaired consciousness or loss of consciousness, then they need to have some kind of pathology bilaterally affecting their cerebral cortices. On the other hand, you can have a very localized focal lesion affecting the brainstem, which is where the arousal center is. And if that's affected, then that can cause loss of awareness or loss of consciousness. So in gross terms, those are the 2 things you just need to think about and consider. In terms of causation, there are a large range of number of possible causes. So obviously you can go through your famous surgical sieve of underlying causes, but there are various disease processes that affect both cerebral hemispheres. Anything that causes raised intracranial pressure can cause impaired conscious level. Trauma, with sort of diffuse severe head injury can cause reduction in the Glasgow Coma score. Cerebral hypoxia or cerebral hypoperfusion. In other words, if the brain is not being perfused due to the blood pressure being very low, for example, or if there is a severe stroke, say affecting, if you have an occlusion of the basilar artery, for example, if you have cerebral venous sinus thrombosis causing venous congestion and causing extensive cerebral ischemia, anything that causes cerebral hypoperfusion can cause loss of consciousness. There are various infective processes that you need to think about, of course, meningitis, encephalitis, cerebral abscesses if they're quite extensive. All of those things can cause reduction in the coma score. And then cerebral or intracranial hemorrhages of various types, including subarachnoid hemorrhage, severe subdural hemorrhage, severe parenchymal intracerebral hemorrhage as well. And these can be spontaneous, or you can get those in the context of trauma or brain injury as well. And then you need to think about possible metabolic causes of impaired consciousness, so ketoacidosis, carbon monoxide poisoning, hyponatremia, hypernatremia, and very important cause you always need to think about is hypoglycemia as well. And then you can have impaired consciousness or coma due to organ failure. So you can get a hepatic encephalopathy, you can get encephalopathy associated with renal failure as well, or uremia. And then think about endocrine causes as well, so severe hypothyroidism, severe hypocorticosteroid problems, Addison's crisis, all of these things as well. And then, of course, there's a whole range of substances that can affect the brain and cause this kind of problem. So large doses of opiates, alcohol, recreational drugs like cocaine, benzodiazepines, antidepressants, obviously general anesthetic. And then brainstem problems, so any focal lesion in the brainstem can cause it. Any lesion above the brainstem that causes herniation of the brainstem due to raised intracranial pressure can also cause it as well. So how do you approach these patients? So obviously the same approach as with any patient. ABC is the most important thing. Once you've assessed those, once those things have been stable and managed, then there are various things you look at as well. Try and obtain a history if possible, if there's an eyewitness or someone who knows the patient. Was the onset of the coma, was it an acute onset or has it been a gradual onset? With acute onsets, you think about possible massive strokes, you think about hypoperfusion due to cardiac arrest, you think about massive cerebral intracranial hemorrhage, you think about possibly head injuries. If it's something that's come on a bit more slowly, over minutes to hours, you think about infection, sepsis, you think about maybe hypoglycemia or drugs. You ask from witnesses if the patient has had any recent symptoms such as headache, has their mood been depressed, is there a chance they could have taken an overdose of medication, have they been complaining of weakness, which may suggest a tumor or something like that. Have they been complaining of vertigo, which may suggest posterior circulation TIAs. So any kind of history would be helpful. Any history of recent injury. Have they had medical problems in the past? Are they known to have liver impairment? Are they known to have a history of alcohol? Are they known to have a history of chronic renal failure? And then when you focus on the examination, basic stuff, obviously the vital signs, temperatures, pulse, blood pressure, respiratory rate, all of those things are important. Look for any skin markers of septicemia or meningitis. And then you do a neurological assessment to look for particular aspects that might help you. So look what kind of posture they're at. We were talking about decorticate posturing and decerebrate posturing. So a decorticate posturing of abnormal flexion would be suggestive of bilateral cerebral cortical problems. If they've got decerebrate posturing or extensor posturing, that would suggest a problem in the brainstem. Do they appear to have a hemiplegia, for example, which might suggest a stroke or a tumor on one side? Is there abnormal movements like intermittent twitching? So could they be having seizures? Could they be in status epilepticus? Do they have myoclonic jerks, which may point to sinister pathology such as CJD or something like that, which can also cause coma? Level of consciousness we've already talked about and how to assess those things. Do they have nuchal rigidity, which might suggest meningitis or a subarachnoid hemorrhage? Assessment of their pupils and eyes are important. Again, they can be clues. Do they have a Horner syndrome? You can get Horner syndrome in association with cervical artery dissection, for example. Do they have dilated pupils, which might suggest an overdose of anticholinergic medication? Do they have pinpoint pupils, which may suggest opioid poisoning? So those are the kind of things to look for when you look at the pupils. So if the pupils are equal size, pinpoint pupils can suggest opiate poisoning from organophosphate, or a lesion in the pons. If they have dilated pupils, they could have poisoning from anticholinergics. It could be related to alcohol, hypoxic brain injury, metabolic abnormalities, and of course raised intracranial pressure can cause dilated pupils as well, which may be fixed. If the pupils are unequal size, then if the abnormal pupil is fixed and dilated, that would be suggestive of a third nerve palsy. Third nerve palsy can be a sign of herniation of the uncus due to raised intracranial pressure above the tentorium. Important thing to note is that about 20% of the population may have asymmetric pupils anyway. It's just something to think about. And then you can try and do more detailed examination of the eyes. Look in the fundi if you can. Do they have papilledema, suggestive of raised intracranial pressure? Try and check for any reflexes that involve the eyes, which may suggest pathology in the brainstem. So, for example, do the pupils respond normally to light? Is the corneal reflex preserved? The corneal reflex is absent or impaired, may suggest pathology again in the pons. Test their doll's eye reflex. So normally when you move patients' head from side to side or up and down, the eyes tend to spontaneously compensate by keeping the same direction of gaze. If that's impaired, that would suggest there may be pathology affecting the brainstem, either the pons or the midbrain. Raccoon's eyes, so if they have bruising around the eyes and the face, that might be suggestive of a basal skull fracture. So I'm not sure if you can see this very well, but just this is the kind of thing to look for when you're testing doll's eye reflexes. So here you're basically moving, what you're doing is moving their head from side to side and up and down. And basically when you move their head from side to side, the eyes should always be pointing straight ahead. Same thing when you move the head up and down, the eyes should be pointing straight ahead. That's an intact pathway in terms of the brainstem reflexes. So if you have a lesion in the right lateral pons, for example, that causes gaze paralysis to one side. So for example, if you have a lesion in the right side of the pons, If you test their eye movements by turning their head to the right, that's normal, so their eyes are still looking ahead. If you turn their head to the left, the eyes don't compensate, and the eyes look to the left with the head. Vertical eye movements are normal. It's okay. So that's a sign of lesion on the right side of the pons. Then, if you look for a lesion, the medial longitudinal fascicular, so that's in the brain's part of the lower part of the midbrain. You have something called internuclear ophthalmoplegia. What that means is that adduction is impaired. Adduction of the eye is impaired. So if you turn their head to the right, the left eye abducts normally to look straight ahead, but the right eye fails to adduct. And the same problem occurs if you turn the head to the left as well. Vertical movements are preserved. And then if you have a lesion in the right paramedian pons, you have what we call a 1.5 syndrome. So you have your internuclear ophthalmoplegia on one side, but not on the other side. And then finally, if you have a midbrain lesion, you have impairment of up gaze and down gaze. So lateral gaze, you get the normal doll's head response, but vertical gaze, they don't correct. So eye movement testing is quite a useful test to help localize the lesion. So further things to look at in terms of examination, look for any fluid leak. Is there CSF rhinorrhea or otorrhea, which may be suggestive of a basal skull fracture? Are there any needle marks in the skin or in the nails, which may be suggestive of intravenous drug use? Assessment of breathing can be very helpful. So the Kane-Stokes breathing, which is a kind of rapid, shallow breathing, alternating with slow periodic apneic episodes, that can be a feature of a number of conditions, including heart failure, stroke, traumatic brain injuries, metabolic problems as well. Kussmaul's breathing is deep labored breathing, usually a sign of metabolic acidosis, such as ketoacidosis, renal problems, etc. So breathing pattern can be very helpful. In terms of investigations, obviously some very basic investigations are important. ECG, basic bloods. As I said, it's very important to check the blood sugar because that's easily correctable. Check sodium levels, etc. You might want to do a toxicology screen as well if there's any suspicion of that. Blood gases, obviously chest X-ray, and imaging of the brain may be important as well. You may want to do some further investigations. If you suspect meningoencephalitis, you want to do a lumbar puncture, for example. District general hospitals, as a rule, do not have EEG facilities, usually. So if you're suspecting a seizure phenomenon, you cannot really get any readily available EEG to check for that. So it's very much a kind of clinical assessment regarding seizures. And obviously you can get many different types, but obviously status epilepticus, secondary to generalized tonic-clonic seizures, is important to be able to diagnose, as if it is left untreated for a period of time can lead to irreversible brain injury. So you should all have a pathway for managing status epilepticus, hopefully, in your handbooks or in A&E regarding that. In terms of what to give, here we tend to give IV lorazepam, and then failing 2 doses of IV lorazepam, we then go on to load with either phenytoin or phenobarbital. Failing that, obviously we ITU involvement in terms of anesthetizing the patient. So that should all be kind of available for you. It's important to make sure that the patient is actually having genuine status epilepticus and is not actually having one of the mimics of epileptic seizures. You know, you can get non-epileptic attacks, or what we call dissociative seizures or psychogenic seizures. The movements may be irregular, somewhat bizarre, asynchronous, variable. The patient may have their eyes closed, they may resist eye opening, so there are various clues for that being the case. Serum prolactin taken about 20 minutes after a seizure or 20 minutes into a seizure can be helpful in the sense that if it's normal, then that would suggest that this is not genuine status epilepticus and it may be dissociative. If it's raised, it may not be helpful because it can be raised in some types of dissociative seizures as well as status epilepticus. And then there are various other seizure types to think about. There's something which is quite unusual, but it's called non-convulsive status, where patients are just unconscious, but don't or have obvious fitting movements or anything like that. But they are in what we call non-convulsive status epilepticus. And usually a good sort of test for that is to actually give them a benzodiazepine such as lorazepam. And often that will bring them out of it and wake them up. So it's always a useful thing to try if you have a patient who's unconscious, possible past history of epilepsy, possibly haven't been taking their medication. They don't seem to be fitting, but they're unrousable. If you give them, say, 4 milligrams of IV lorazepam and they come round, that can be helpful in terms of diagnostically as well. Okay. So this is really just a kind of basic algorithm to go through. So obviously we talked about basic ABC, the importance of supporting them. Obviously get the critical care team involved early on, pretty much right at the start actually, because if there's any signs that they're not protecting their airway as a result of being unconscious, then of course the management has to go to another level in terms of intubation and supporting airway, supporting breathing, etc. But basically, obviously, make sure you have IV access, give them oxygen. If there's any suspicion of any kind of injury, stabilize their cervical spine. That's important. Check their blood sugar very early on because it's easily correctable. And as we sort of talked about seizures, if you think they're having seizure activity, it's important to manage their seizures and to control their seizures properly. And then consider giving empirical treatment. So, there may be a possible history of alcohol, there may be a possible history of benzodiazepine usage or overdose or opiate overdose. So, think about giving them empirical, potentially reversible treatment in terms of giving them glucose, giving them thiamine, consider opiate antagonist, consider benzodiazepine antagonist as well to give them. Obviously, examination is going to be limited because they're unconscious, obviously, but, if you look for the things that we discussed before, it can give you clues as to potential problems, etc. And if you can obtain a collateral history from relatives or partners or even witnesses, someone who was there when they appeared to lose consciousness, that can be very helpful as well. And then obviously we talked about the sort of basic investigations that need to be done to look for possible underlying causes as well. And then if the patients haven't recovered, if they're still unconscious, reassess again and think about what further investigations that may need to be done. Do they need to have a lumbar puncture? In some cases, there may be cerebral pathology that's not picked up on CT, and you may need to consider MRI scan to look into certain things further. For example, is cerebral venous sinus thrombosis, which may not be picked up on a CT scan, and you may need MRI imaging to detect that. Brainstem strokes, for example, may not be picked up on a CT scan, and you may need MRI to look into that further and to investigate those other possibilities. as well. And then obviously cardiac things is very important. One of the commonest causes of loss of consciousness is cerebral hypoperfusion. So the primary pathology is not actually in the brain. It's actually a cardiovascular issue, either due to cardiac arrhythmia or severe heart failure, for example, or due to severe bradycardia, all of those things. So always think about a cardiac assessment as an underlying cause. That side of things is very important. If it's a transient cardiac problem, then most patients should recover consciousness fairly quickly, unless the cardiac event was a prolonged cardiac event. Did they have cardiac arrest, for example, or did they have a very prolonged hypotension? If it was prolonged, then obviously that may have led to more permanent cerebral injury, hypoxic injury, in which case they may not recover consciousness quickly. And then again, in the acute stage, a CT scan may not show much evidence of that, and an MRI scan may be more sensitive at picking up some signs of that. The presence of myoclonic jerks can be helpful. We talked about myoclonic jerks in the presence of CJD. You can get myoclonic jerks following prolonged episode of cerebral hypoxia as well, and that's a sign of the sort of beginnings of hypoxic encephalopathy developing as well. So all of those things are quite important to think about and to assess. Does anybody have any questions in the meantime? I think we've got to wait. Sorry, we've got to wait for the microphone, I think. Here we go. Microphone behind you. Was the lady at the back? Lady at the back. Oh, there we go. Yeah, she's denying it now, but it was her. Yeah.
It's a really basic thing. With the GCS, when you're saying localizes to pain and withdraws from pain, the difference being what they try and hit you, get off me.
Yeah, so localizing to pain is that they will sort of focus on the pain. They will withdraw, but also aim to localize.
I feel a lot of withdrawal, and I think, well, I've obviously just done some noxious stimulation. They move their hands away. So is that localizing or is that withdrawal?
So basically, localizing to pain is that they will withdraw that particular limb to it. But withdrawal is that you have a generalized withdrawal response, limbs and the legs as well.
Oh, thank you.
Yeah.
You mentioned earlier about when the patient's unconscious, we can trial lorazepam as well. I'm just unclear about when we're actually going to be given that. So we do the whole ABCD, and we're ruling out different causes, but when can we just give diazepam? Because if we see a patch on the patient, the pain patch, we remove that, give them naloxone, but there's an indication something's going on. Usually with lorazepam, we see them shaking or something going on. Just seeing them not moving, it's just
yeah, I wouldn't give the lorazepam straight away. So if you've basically got an unconscious patient who's not moving at all, obviously you need to look at other possible causes. So as you say, if you see that they've got a pain patch on, things like that, is there any suspicion that they've had a cardiovascular event, or have they had a major stroke or something like that? Any metabolic factors? So you'd always look for all of those things first. And then I think if you've excluded those as much as you can, then it would be perfectly reasonable, I think, to give them just a trial of lorazepam, just to see if they come out of it. Yeah.
Same dose as a seizure? Or?
Yeah, 4 milligrams. Yeah. And I think particularly what we tend to find with non-convulsive status is it's very rare. I mean, we do have, nothing is impossible. We do occasionally see it, but it's very rare for patients to present as epilepsy with non-convulsive status. So the vast majority of times you'll see non-convulsive status is in patients who have got a background history of epilepsy at some point.
Thanks.
Okay. Any other questions? It's going to be a very short talk otherwise. Are you is everyone happy about the sort of the surgical sieve in terms of the different sort of causes to look for? No questions about things like that at all? Yeah. Everyone happy about the difference between sleep and unconsciousness? Yeah. Did you have another question? You were sort of semi-raising your hand, didn't you? No. Okay. All right. Okay. So as I said, we normally, with this kind of setup, we have a kind of case presentation as well, but unfortunately we didn't. Person who was meant to do that wasn't available, so we didn't have. Oh, sorry. Yeah. Okay. You'll have to shout out then. Yeah, so some patients, as well as having epilepsy, they do have dissociative seizures as well. So we do sometimes find, and a lot of these patients are quite complex patients. They have quite complex sort of psychosocial issues going on as well. So they have a diagnosis of epilepsy, they're on anti-epileptic medication, which then may control their seizures. And then for whatever reason, whether it's some kind of psychological trauma or something happens in their lives, and their epilepsy may be well controlled, but the way that they subconsciously try and adapt to this trauma or react to this trauma is by exhibiting dissociative seizures, and we do sometimes see that. You know.
Just remembered something. I think maybe 2 months ago, I was on call and I went to go see this girl. She was around 20 years old. They diagnosed her as, well, they queried whether it was all psychogenic seizures that was happening. So when I went to see her, she was screaming. She started out screaming, and then she was just shaking. She was completely stiff, and she was just shaking in her bed. And then her heart rate went up to about 160, 170.
Yeah.
Her blood pressure was around 180, 160, just kept on fluctuating, going up. Did an ECG, which showed it was around 130, 140 as well. Sinus tachycardia. Her pupils were dilated as well. And what happened was that the nurses explained to me that she was initially in the side room, and she was fine when she was in there. She was walking around outside anyway. And then when they transferred her from the side room to the bay, the seizures started again. Her admission was for the seizures, and she was having about 6 to 30 episodes a day. And she used to be a carer of patients who had epilepsy in her home, so she knew the characteristics and how it would happen anyway. So they just went down the pathway of saying this is psychogenic. They ordered a CT scan, which was normal, and they were waiting for an MRI. So when I went to see her, she was having these seizures, and then she was biting her tongue, and I couldn't open her jaw. It was completely stuck, and it was just getting engorged and blue, and she would just scream and shake. I remember calling the medical registrar. He said, just leave everything, tell everyone to leave the room, and she'll be fine. Just leave it, just get out of the room, take everyone and just leave the room. I gave her lorazepam because I thought it'd calm her down. No, I gave her lorazepam. I did give her lorazepam. Yeah. And that didn't work. And she was still tightening her mouth, because I was worried that she was about the tongue. I didn't know what to do.
Yeah. Yeah.
So what would you recommend at that point?
Yeah, I mean, obviously that's a difficult situation. One of the features of tongue biting with epilepsy versus non-epileptic seizures is that with genuine epileptic seizures, patients tend to bite the sides of their tongue, whereas if it's the front and the tip of the tongue, you tend to see that more with dissociative seizures. In terms of what you describe, that to me sounds more like a dissociative seizure than an epileptic seizure. First of all, the frequency of seizures, having up to 30 attacks a day, is a bit suspicious. If it's not something that we usually see with epileptic seizures. Some people with severe epilepsy can have very frequent seizures a day, but to have generalized tonic-clonic seizures 30 times a day is pretty unusual in the context of epilepsy, I would say, context of true epilepsy. Those kind of signs that you picked up in terms of the pupillary dilatation, the tachycardia, and the hypertension, these are all just features of adrenergic activation, aren't they? So anything that puts your adrenaline levels up will cause those features. So, any kind of stressful situation can do that. By themselves, they're not necessarily pushing you towards epilepsy versus dissociative seizures. One thing that is helpful, which I forgot to mention actually in terms of blood tests, is to check the white cell count. So white cell count does reliably go up in true epileptic seizures, whereas tends not to do so with dissociative seizures. So that's always worth doing, as well as obviously checking prolactin, which can sometimes be helpful and sometimes not. But in terms of sort of self-injury and things like that, when someone's having a seizure, whether it's dissociative or epileptic, the first thing to do is obviously make sure that they're in an environment where they're not injuring themselves. Absolutely put them in the recovery position, irrespective of what. And in terms of injuring the tongue and biting the tongue, what you mustn't do is insert your fingers to attempt to open the jaw at all. That's just not doing that. Patients do injure their tongues, but the point is that it will heal itself. Yeah, I've never seen a situation where a patient has actually bitten their tongue off or the tip of their tongue off, from epileptic seizures or dissociative seizures. So yes, there will be tongue injury, but it will heal.
She actually got better as soon as she went back in the side room.
Yeah.
So
Yeah.
we shifted her back in there. It went dropped from 30 to 6.
Yeah.
Okay.
Yeah.
Thanks.
Hello. So I was working on Newington Ward, and there was an elderly lady who had a history of trigeminal neuralgia. So she was on carbamazepine for that, and we decided to increase it because the pain was worse and not controlled. And we looked at the BNF and thought, well, she could go for 3 times a day, I think it was at that point. And then when I saw her the following week, she looked like she could be in a non-convulsive status with eye twitching. It was not typical of her at all, and it was one of those really difficult to assess if she's kind of with it in between, because they happen so frequently.
Yeah.
And I felt that we really should give some lorazepam,
Yes.
because she had a history of cerebral palsy.
Yes.
I don't think she had an overt history of epilepsy.
Okay.
So we gave the lorazepam. The nurses were freaked out at the dose, and I was following what the guidelines were.
Yeah.
And then she was just super sleepy for so long that they put her on an end-of-life care pathway.
Oh no. Oh, dear.
Until I said,
Yeah.
could it have been that? And then she got better.
Okay.
And I think it just took a long time for, that's my feeling, that the lorazepam just sent her too sleepy.
Yeah.
She
So
got
do you think
better.
the lorazepam helped to bring her around then? Or
No.
it was just
I think she just got super
just the drugs.
drowsy.
The drugs just got out of the system.
Yeah,
and she
and the
woke up.
twitching stopped.
Yeah. Yeah.
But then I wondered, was it carbamazepine toxicity? And
Yeah.
we've done that, and is that a sign? It was very odd ocular
Yeah.
movements,
Yeah.
repetitive,
Yeah.
flickery, and it could have been a non-convulsive status.
Yeah.
I couldn't tell.
Yeah, I think that was probably drug-induced toxicity. So
So
one of the
carbamazepine.
problems, as you probably know, one of the problems with carbamazepine is that it's an auto-inducing drug. So carbamazepine is one of those drugs where it's really important to titrate very slowly. And I think the BNF guidelines, if you look at the BNF on titration, they get it completely wrong. They do it way too quickly. I introduce carbamazepine really slowly to my patients, sort of 100 milligrams once a day for 1 week, then 100 milligrams twice a day for 1 week, then 100 milligrams 3 times a day for 1 week. I do it much very gradually because it's an auto-inducing drug. So basically, if you look at the graph of the level, if you look at the dose, level graph on carbamazepine, it sort of shoots up and then it flattens out. So basically, you always titrate very, very slowly. That's the important thing.
So it should have been on a long-term BD dose, and then we just introduced a third dose.
Right,
looking at the BNF.
right.
So
Yeah. Yeah.
I didn't quite know what the right thing to do was, given that we don't have EEG here.
Yeah. And then in terms of the twitching, paradoxically, carbamazepine can induce seizure activity. So a typical example is in patients who have a history of a particular type of epilepsy called idiopathic generalized epilepsy or something like that. And there are some of the sodium channel blocking antiepileptics can actually make that worse. So things like carbamazepine, phenytoin can make that type of epilepsy worse, or it can trigger that type of epilepsy sometimes at sort of toxic doses. So those drugs, those sodium channel blocking antiepileptics, can paradoxically induce seizures at high dose. So I suspect that's probably what was going on with your patient, I think.
Where we totally cut down, and then she got pain.
Good.
Thank you.
Any other questions? No? Okay, we'll wrap it up then. All right, thank you.